Right, because I like to move around a little bit. All right, so I know we do have some veterans on the virtual space because I do have some friends on there, so thank you for your service as well. If you are related to a veteran, please stand. And remain standing. If you have a coworker that's a veteran, please stand. A church member that's a veteran, please stand. Okay? As you can see, that we're all connected to a veteran in some capacity. So we have the potential to have an impact because we're connected to them. Thank you so much. You all can sit down. So this is going to be an interactive presentation because I don't believe in just talking to people and then I'm just up here doing all the talking. So if you have questions, please go to the microphone and ask those questions. We're going to be talking about the opioid epidemic among veterans and focusing on the battle, removing the stigma. All right, so this is a crisis and it's a significant problem that is affecting everyone, but mainly it's affecting the veterans, okay? And so we're going to look at this group because it's one of the highest risk opioid disorders and dependency, and they experience a lot of chronic pain. Can someone share why is this population experience a lot of chronic pain? If you would just stand or come to the microphone and just give an idea of why you think this population experienced a lot of chronic pain. The training is very rigorous, absolutely. Getting prepared for combat and deployments and missions, it is a lot. It takes a toll on the body. Anybody else? Multiple injuries, okay? Anybody else? Things that they've seen and heard, okay. What about the deployments? Deployments. What about those? Does that take a toll on the body? Okay, all right. So this population experiences a lot of chronic pain because of the training, the deployments, and they come back with a lot of different injuries, okay? So there's 562 veterans that abused opiates in 2018, and the number continued to increase as well. So in this presentation, we're gonna address the opioid dependency in veterans, and we're gonna look at the risk factors, and we're also gonna look at the stigma that's associated with it. And then we're gonna talk about some treatment recommendations. In the veteran population, we've talked about the reasons why it's very prevalent in the veteran population. So there's approximately 60% of the US veterans who were deployed to the Middle East, and they experienced some chronic pain and are on opioids, okay? And then prior to that, there was 50% of veterans who served in other areas who are also using opiates to manage their chronic pain. So between 2010 and 2015, the VHA recorded a 55% increase in veterans that were diagnosed with opioid use disorder. So we're looking at approximately 418,000 veterans who meet the criteria for this disorder. It's quite a bit, right? Okay. So they're at risk for chronic pain compared to the civilians because the veterans are 40% more likely to experience severe pain. And we just talked about some reasons why. The training, the deployments, the missions. That is why the number is so high. So based on the National Health Interview Survey data, 67,647 self-identified as veterans. The reason why I did the exercise, it was part to get you all up and moving because I know you just had lunch, but also to let you all know, we all know a veteran in some capacity, okay? So when we're looking at the non-veterans whom only 56.4% reported pain and 6.4% reported severe pain, overall, we have 1 in 5 veterans who report persistent pain 1 in 10 veterans that report severe persistent pain, and then 1 in 3 veterans have been diagnosed with a condition that's related to chronic pain. So when we're looking at some of the common abused drugs, marijuana is number 1. 11.1% of veterans use marijuana. And then the next one is psychotherapeutic drugs, and that is Ambien, Lunesta, Valium, Xanax. And then the third one is opioids, okay? So we talked about the prescription drugs are commonly used among veterans. But when we look at the 2.7% of the total population of veterans, we're looking at 505,000 prescription pain relievers that are misusing those drugs. So in 2017, 67.8 of drug overdoses in the US were due to prescription opioids with the rate of opioid use disorder among patients in the VHA system, which is 7 times higher compared to that of non-VA patients. From 2010 to 2019, there was a significant increase, 53.2, in age-adjusted overdose mortality rates among veterans. Okay, so let's talk about some of the risk factors. We talked about the multiple deployments. We talked about the combat exposure that leads to trauma and post-traumatic stress. We talked about the service of combat-related injuries that require chronic pain management. We've also talked about the increased access to opioids. So in the DMV area, if you drive 45 minutes to 2 hours, you have 4 to 5 VAs in your area that you can drive to. I know here it's Shreveport, Alexandria, and New Orleans. But in my area, there's a lot of VA hospitals. So what you have is they will drive to the other VAs to get prescriptions. They will also tell the doctors they got lost in the mail. Can you give me some more? They'll borrow from their other veterans. Okay? So let's talk a little about the stigma. When we talk about veterans, we think about strong, dedicated, loyal. Why is it so hard for a veteran to receive help? You're supposed to be strong and not ask for help. Okay. Let me hear from some of my vets. Because I know your families probably think you're something stubborn, don't want help. You're taught to suck it up. It's part of our culture that you don't ask for help. Because what that means is it's a sign of weakness. And if you're weak, you can't carry out the mission. You're a liability to your unit. Okay? So that's the stigma that people don't like to get help. They're hesitant to ask for assistance. Also, if you ask for help, it could hinder your career. You might not get promoted. What'd you say? And in the military, getting promoted is very, very important. Okay? So if I ask for help, that may cause me not to move to the next rank. Right? Okay. All right. So approximately 60% of veterans with substance abuse problems fail to seek treatment, mainly due to the stigma. Because it doesn't stop when you're in the military service. That continues on as a veteran. Because it's ingrained in you. You do not ask for help. Okay? So the military, we talked about it, promotes values such as toughness and being self-sufficient. These values often continue after we leave active duty. All right, next slide, please. Okay. So also one of the stigmas that's associated with is the illicit drug use disorders. They're perceived to be weak. We talked about that. They have bad character, especially when it's compared to other mental health issues that they have, like post-traumatic stress, depression, anxiety. So we have challenges to prevention and treatment. And during the pandemic, we saw a lot of challenges to treatment. Even though telehealth and telemedicine expanded tremendously, we had a lot of people that did not go in for services. They missed out on mental health appointments. They missed out on their peer support groups. Also, we had people not, their surgeries were rescheduled, so they were over-medicating during that time frame. So when it comes to the providers, they may demonstrate harmful attitudes and behaviors that make veterans to get help even if they wanted to. We're getting a little bit better with that by working on the terminology that we use. I still hear some people say they popped, they were dirty, their results were not clean. And we're trying to change that terminology and replace it with relapse and recovery. Instead of substance abuse, we want to say substance abuse disorder, okay? But you'll still see some people still using those terms. All right, in 2014, the Opioid Safety Initiative was developed. And this was a system that was in place at the VA where we could see who are getting medications at different VAs. Before this, we were not able to look into the system to see what medications they were receiving. So in Louisiana and Maryland, we have a similar programs, the prescription monitoring program, which was signed into 2017, which is an electronic system that monitors controlled substances. With this, we're able to monitor, but with certain drug interactions may cause or assist with the assist with more abuse and overdoses. Okay, so one of the drugs that we can't monitor is marijuana. Does anybody know why we can't monitor marijuana being used with opiates? Because it's being regulated on the state level and not a federal level. Each state is taking their time to legalize marijuana. Okay. So everything we do is driven by our belief that it will bring us close to some sort of happiness or benefit. Do you all believe that? Does anybody disagree with that? Come on, like. You agree. So when we are thinking about people that are using medications, they feel like it's a benefit to it. It's going to bring me some type of fulfillment, some type of joy, some type of relief. And our society and culture has taught us that medications cure all. So if I pop this pill, it's going to take care of X, Y, and Z. Okay? So these are some of the things that I hear from my patients. For the trauma that I experienced, the medications help with that. For my social anxiety and depression, it helps with that. It helps to relax and ease my pain. I want to feel normal, so I take a pill. To wake up in the morning, I need to take a pill. Okay. To make it through the workday, I take a pill. To go to bed at night, I need to take a pill. To be creative, I need to take a pill. I've even heard even to go to my kids' school functions and sit there through a program, I have to take a pill. To have a clear mind, I need medication. So some treatment interventions. We use mindfulness and we try to get them to refocus their thinking and their belief system that we don't need medication to cure everything. We can work on changing our belief system. Pain does not define who you are as a person. We also use whole health, and it supports the health and well-being, and it places each person at the forefront of their care. We use acceptance and commitment therapy for pain, and this is just helping them to be aware. Yes, I do have pain. Also, it helps them to really think about their beliefs, their thought process, their values, because sometimes they forget about things they valued once, or things that they may have lost as a result of them using. So these are some treatment interventions that we use. Some other treatment strategies. We want to limit the opiate prescriptions to short-term for acute or terminal chronic pain, and think about some other things that might be beneficial, like exercise, a diet, weight loss, minimal invasive surgery, or other medical treatments. We also want to do education and awareness and prevention programs. Prevention programs, they cost money, but it's an investment into our community. I like to look at it like a retirement account. You put it in there, you invest in it, and then long term, you'll see the results. So we have to look at our prevention programs like that. Yes, they cost us money, but what is going to be the long-term benefit? So there's prenatal prevention programs where nurses can go out and educate the parents. There's middle school intervention programs, and there's also family-focused intervention programs. I know when I was going to school, DARE was really, really big. Do you all remember DARE? Okay. So also some non-opioid medication and treatments as well, like electrical stimulation, bracing, workplace modification. I had to do some workplace modification at my job. I have a standing desk to help out with my back. You got massages, you also have acupuncture that can help you as well. These are some other alternative treatments that can be beneficial instead of using opiates. All right, so we want to do the community partnerships. We want to make sure we develop relationships with the school system, the police departments, and I know a lot of you all are doing a lot of great work in the community and you have these partnerships in place already. We want to make awareness be brought to the communities through social media. Also, they have radio station ads that are very important. When I was on my way to the airport, they was talking about what to do if someone has an overdose. Do you know what to do? And so the ad was just advertising and educating you about the benefits of knowing what to do if someone was to have an overdose. Okay? And effective communication. We want to make sure we increase public support for not only harm reduction initiatives, but also evidence-based. On a large scale, we want to reduce the stigma. And that's how we work on how we treat people. We want to make sure we make them feel like a human and let them know that this is a disorder that you have and that you're suffering with. So we want to use evidence-based recommended care, practicing opioid prescription. We also want to create awareness of the risk factors among veterans, which we talked about in detail. We want to treat the core conditions such as PTS. We want to educate the military leadership to reduce or prevent stigmas and let them know that it's okay to get some help. That's not a sign of weakness. We want to provide confidential care for veterans and officers with opioid abuse problems. Because one of the things is they don't want people to know that they're going to get assistance. And they want to know that it's going to stay right there. So good habits are easy to form and easy to live with. Bad habits are easy to form and hard to live with. But pay attention and be aware. If we don't consciously form good ones, we will unconsciously form bad ones. What do you all think about that quote? Okay. So life can be challenging, and it can be difficult for some individuals, but we want them to know that recovery is possible, and so is joy. Questions? You coach it.
Okay. In your work with the veteran population, what would you say is one of the hardest things or one of the biggest barriers you face in working with, and I'm sorry if you've mentioned this because I had to step out, but in working with getting them, even just recognizing the need for treatment?
So just educate them on the benefits of getting help, and like we talked about, reducing the stigma about, because they're ingrained in them that you don't get help. And so trying to change the narratives and so they understand that we can reach out and get help. And there are providers here that understand what you're going through.
Okay. Okay. Do you see a lot of veterans with opioid use disorder and co-occurring with PTSD?
Yes.
Okay.
Yes. And we see a lot of, we went through it a little bit earlier, that they'd say that, you know, I need this to get up and get going, or I needed to change my mood. In reality, we need to treat the PTS, and you don't need to use the opiates to deal with that.
Okay.
Mm-hmm.
Okay.
Okay.
Hey, so we greatly believe in Western medicine, but you talked about acupuncture. How close are we getting to using some more Eastern practices other than acupuncture?
Give me an example.
The Reiki healing.
So we actually have a Reiki group at my office. So we are doing that as well.
Oh,
yeah.
Okay, interesting. Thank you.
And it's so funny that the counselors come in, they was like, oh, today's Reiki, because they smell the incense and everything in the office. Yeah. But we are doing that already. Because everybody doesn't want to do traditional evidence-based therapy. So we're trying to have alternative treatment options for the veterans. So we're doing yoga, we're doing Reiki. We're also doing yoga, Reiki, meditation. Yeah. You're welcome. Any other questions?
Do you have an idea about how many veterans you've reached so far?
In my clinic, So in our clinic, we have about 450 veterans on our caseload. And I'm on a small clinic, so yeah, that's not the entire VA. Yeah. Any other questions or concerns? Yes, sir.
All right, Dr. Gatson, we heard your resume and bio and saw a lot of the things that you're doing and your information you shared. Tell us a little bit about some of the experience you have or things you've seen in veterans. Northeast Delta has a veteran initiative. We've partnered with Louisiana Delta Community College to work in terms of workforce, but tell us a little bit about some of those things you've seen that are biggest obstacles for veterans as they come back home and dealing with opioids.
So some of the biggest obstacles is readjustment, actually getting back into society, what that means finding a job, finding their purpose. Some people are in the military because they know their purpose in the military and they have a stable financial career. So it could be finances, it could be a house, it could be a job. So I see a lot of those things when they come back, helping them find their identity.
And then the next thing is something that we often don't talk about here in the South, but part of your resume also talks about your work with the LGBTQ community. How does that, or what type of work or experiences have you seen around that and those family members in terms of their mental health?
So working with the LGBTQ plus population, I am seeing that they have a lot of issues and resentment towards the military, and they don't want to be associated with the military because of the experiences they dealt with while in the service. So we're just trying to educate that there's resources and services out here to benefit them and help them, and that we serve all.
Give me 1 second, let me see what our virtual folks are saying. Are there any veteran-specific treatment centers, inpatient, in the United States?
Is there any?
Any veteran-specific inpatient treatment centers?
Absolutely. There's several treatment centers throughout the United States. You go to your primary care provider and let them know that you're interested in an inpatient program. They'll do an assessment for you, and they'll reach out to see where is availability for the inpatient facilities. A veterans wing, okay. Yeah, yeah, yeah.
I have another message that's come in. Family of veteran with PTSD, anxiety, anger, and aggression are feeling the effects of their conditions. How do we help the family deal with these issues?
I think it's important that we teach the family members about their triggers and what is a trigger. Triggers, anniversaries, all of those different things, because if we can be educated about the triggers that they may have, we would know how to respond to them in a better manner.
It is our understanding that 85% of opioid users use tobacco. I wonder if you have any special programs for tobacco treatment.
So we do. We do have some programs to help individuals that are struggling with tobacco. They can come in and say that they want to do an outpatient program. So we have some outpatient programs for that.
Okay, great. Thank you.
Now, I know here in the Monroe area, they do have a CBOC, which is a community-based outpatient clinic, but the closest VA medical center would be Shreveport to the Monroe area.
Well, Northeast Delta does have a tobacco treatment program. I'm actually one of the tobacco treatment specialists, but I didn't know how it's being treated outside of this area. So I know that in Louisiana, Northeast Delta is the only agency that has tobacco treatment as part of the program. So I'm really, wondering where and how it's being handled in VA clinics and elsewhere. So I thought maybe you had insight into that.
Yeah, so I would suggest that you reach out to the CBOC clinic, and if you had a veteran that you wanted to refer over there, so because their services are free at the CBOC, and just ask them, do you all have these services? Because we do have them, and if they don't have them, they can refer them to your agency and pay for the services.
Great. Thank you so much.
No problem.
Couple more coming in here
Okay.
from the virtual space. Once a veteran enrolls into a treatment program, is this a long-term enrollment, or have you seen veterans able to sustain their mental status themselves?
Once they enroll in an inpatient program, are they able to maintain it
Yes.
after they're discharged from the program?
I guess the question is it a long-term enrollment, or have you seen them able to sustain mental status themselves?
So as far as treatment, it's a case-by-case situation. So we have seen some success stories where people have went through evidence-based programs and they graduate from the program and they have been able to maintain afterwards. And then we have seen some where we have to continue to get them some extra help outside of those programs.
The next question I have, are there online support programs for patients and families for those who have problems with transportation?
Yes, since the pandemic has started, there's a lot of online groups. So if they're interested in a support group, I think they should look, close for their local VA medical center if they have a spouse support group or a family support group.
Someone wants to know about the services being handled as far as fees go. It says, are they scam-based or are they free? They down to the nitty-gritty on you, Doc.
Talking about the services at the VA, and I know you can't ask them because they're virtual. So the services are free at the medical center if you are a disability, you have a percentage rating for disability. If you're 100%, of course, you can go to any VA and your services will be taken care of. But it just depends on your disability rating that you have. Then you may have to have a copay, and they will take that from your insurance if you have insurance.
Okay. Going back to LGBTQ, seeing how it's Pride Month, in what ways have you seen LGBTQ folks struggle with mental health that they feel they need opioids to be better?
So we participated in the Pride Festival and Parade, and we had a lot of different LGBT veterans come up to our table and just really tell us that they was glad to see us present because they often feel like they're forgotten about. And so when it comes to opioid addiction, it could start from recreational, or it can start from wanting to feel a certain type of way to deal with their moods or things like that. So the numbers are really high with the LGBT veteran population that are using opioids.
Wow. Mm-hmm. Explain the process to registering for services if a vet is not connected to a VA system.
Okay, so there is a number that you can call. I can get that information and you all can share it online for them, but you can also drop in any of your local VA hospitals or community-based outpatient clinics and they can get you registered. You will need a copy of your DD-214, something that states that you are a veteran, or ID or something, or some ribbons or something that you had to let them know that you were in service, and they can get you registered.
Okay. Are there any other questions from the in-person?
Y'all are a quiet audience.
The virtual folks had it coming.
I know, right?
There's power behind that keyboard, though.
Yes. All right, if there's no more questions or concerns, I just want to say thank you all for having me. It's been a pleasure. Oh, one more, I'm sorry.
Does the VA offer virtual meetings for doctor appointments or strictly via in-person?
Yes. It just depends on where you are. Some of the VAs are still not back 100%, so they're offering 100% telehealth. Yeah.
Telehealth is available.
Yeah.
Awesome. Let's give a round of applause for Dr. Gatson.
Okay. All right, so if you want to reach me, here's my contact information. I also do consulting and supervision and coaching for any other providers that want to work with the veteran population. So it's my resources. And they will be, the PowerPoints will be available, and they'll get those to you as well, and my references, okay? All right, thank you so much.